Hey everybody, welcome back to another episode. I today have a person that I went to school with, another friend of mine. They're all friends of mine at this point. Dr. Michael Lovich is here. He's a doctor of chiropractic practicing out in Colorado, and he also has his master's in sports medicine, and also he's board certified in functional neurology and exercise science or sports medicine, along those lines. Anyway, he's got lots and lots of stuff to talk to us about today. So welcome, Dr. Lovich. I'm excited to have you. It's great.
Thanks for having me.
Heck yeah. So burning question, what a lot of people are wondering about right now, how's everything going? COVID, all that stuff is happening right now. How's that been impacting you, and what are you up to?
So we closed down on March 15th voluntarily. We think that it may receive some heat, but we believe that most of the services provided by chiropractors and functional neurologists are not essential for preventing the spread and loss of life due to a viral illness.
Sure.
So we closed down right away to say we don't want to be part of the problem. We don't want people coming to a place where they may catch it or spread it, and we just want people to stay home because one of the things that we know about COVID is that it likes to attack or likes to nestle itself in the bottom of the brainstem in the cardiorespiratory centers. So the number of people that we have coming in who have dysautonomia or vasovagal syncope or POTS or blood pressure changes or yada, yada, yada. You can go on and on about all the parts of the bottom of the brainstem that we work with. We're like, yeah, so if we get them in to try and fix their dysautonomia, wait, now we're putting them at risk. If they get this, then it's basically like game over. That's going to make our jobs a bunch tougher. It's also to give them a bad day. And I mean, we're here to get results, not to pat our own pockets, right?
Right, totally. I think a lot of chiropractors are or just people, a lot of physicians that aren't, in the hospital system are kind of in that same scenario in a way.
Yeah, I'm from New York City, the New York City area. I'm from Central New Jersey. My whole family is from Brooklyn. And a little bit from Queens. It's nuts. I know a ton of people who have had it. I know some people who have died from it. I know people, like my parents own an independent pharmacy in North Brunswick, New Jersey, and they're in their low 60s, and they can't close because people need their medication. So I feel like people complaining about, oh, we have to stay home or we have to do something to protect the person next to us, versus where I'm looking at my parents who can't close and can't protect themselves. I feel like I can shut down. I could take a little bit of a hit to I mean, at least symbolically to do that.
Yeah. Well,
we have offices in Boston. We have an office in Boston, an office in Providence, Rhode Island, and an office in Denver, Colorado. Mm-hmm. And it is when you're dealing with multiple, so each state has their own, this is what we're doing about this. And in order to keep things from getting complicated, we just took it all together and said, this is what we're doing that covers all the states. And so here in Colorado, we've opened up. I see people on Wednesdays and I see people on Sundays to give enough time in between where hopefully there's no contact.
Yep.
And it gives enough time for the protein to denature itself. We also clean everything, wear masks, or we have face shields because some of the times we need to be able to see what's going on with facial features and autonomic changes. And so throwing a face shield on a person still protects the patient and protects us, but it allows us to get the job done.
Sure. Well, that's encouraging, though, that you were able to open up in Colorado. I know Oregon here, we never really fully shut down. But there were still, I basically didn't see people in person for quite a while, just simply because it was kind of under the directive of if somebody could suffer from like irreparable damage, that was like the only cases that you were allowed to see. So so we shut down for quite a bit too, but now stuff is starting to open up again and people are starting to venture out a little bit more. Same thing, got to wear masks, all that kind of stuff. So yeah,
I was highly entertained by watching people do some pretty impressive, like Olympic level mental gymnastics to philosophize how their skill set prevents irreparable damage.
Oh yeah, I mean, it got kind of out of control there for a bit. Yeah, it was a little rough. I'm not gonna lie. But we actually, you and I had a conversation about how to take some of our stuff online.
Mhm.
That's something that we did. Is with a lot of my functional medicine patients, I was able to bring them online and do telemedicine type things. And I think I learned a lot through that scenario, that there's a lot of patients that are kind of far away from where I am. They drive quite a ways to come see me in person. And I think for some of them, it turned out to be a little bit more
You must be
convenient.
pretty good.
I mean, I don't know about that. I think that there's just a lot of people who are looking for care that's just different, and so they'll come a long ways in order to find somebody that will just is looking at things a bit differently than what they're used to.
I
But
think it's a good idea. We started doing that too. Anybody that we could take online, we would
yeah,
offer that at least. We had a significant patients that chose to go that route. The problem with it, and we talked about this, is the licensure that we have. We have
totally.
to start patient care in person. I know Oregon
Mhm.
passed a law that said that at least during the COVID times, you can start patient care online.
Yep.
But Rhode Island, Massachusetts, Colorado didn't change that at all. So I was limited to, or I'm still limited to people who I've seen in person, which
Mhm.
seems kind of counterproductive, especially in the functional
Yeah.
medicine world. That
Yes.
because I have more training,
Totally.
I have more restrictions.
Right. I know. Yeah. And I don't want to kind of go down this road a little bit too, because we could go down a rabbit hole and be there for a whole while with licensing and stuff. But it's true. I mean, I think that there are so we had a policy as well that I have to see you first in Oregon State in my practice before I can treat you online. It's very similar across the board for pretty much everyone. And then once we've done that, then we can do telemedicine visits from there. And so since Oregon did sort of kind of tweak that a bit, there's been a little bit more leniency, but I still have been fairly cautious about that because I just don't want any, how
And
it
we're
goes.
using that to our advantage in a way for the patient's benefit, because in Rhode Island and Massachusetts, now that we're able to see people in Rhode Island,
Yeah,
now we're saying, okay, come on in for
right.
your first appointment. We're going to have people very spaced out and clean the entire everything in between.
Yeah,
And then anything that we can do online, we will do online.
right.
So instead
Exactly.
of doing like 2 visits a week where we do like half nutrition and half rehab, we'll just schedule it where 1 visit a week is rehab completely and 1 visit is nutrition. And they don't come in for the nutrition one.
Yeah, that sounds awesome. I love that. That's great. So I want to ask you a little bit about functional neurology. I'm very familiar with it, but I know that a lot of people aren't. And I know that I see a lot of patients in my clinic that I'm like, have you thought about seeing a functional neurologist? And they're like, what is that? So why don't you go ahead and just give a bit of an introduction about it? And then I'm excited to kind of go down that path with you.
So let's give a little bit of context to start that.
Yeah.
I want everybody to think of integrative medicine as people who cross-train in a number of different specialties to make sure that the specialist approach and the pitfalls of the specialist approach doesn't happen. So one of the major pitfalls of the specialist approach is you have a cardiac specialist, you have a GI specialist, you have a brain specialist, and they don't really talk to each other. So you have these silos of expertise, and you have all these patients that are probably more in between 2 of them, and the gap in the middle is where they just fall right through. So within an integrative model where we look at a musculoskeletal perspective, like you learned in chiropractic school or physical therapy, we also look at a functional neurological model. And the reason why it's functional neurological, or some people call it clinical neuroscience, is because we're looking at patients from a neurological perspective, and we'll do a lot of the same testing that you'll get from a medical neurologist. However, especially the bedside exam. However, the difference is where they may be looking for pathology. They'll be doing a test to say, does it work or not work? And like you know from your education in chiropractic school, you do your cranial nerve exam, you're looking to see, is it broken or is it more or less intact? However, if it just because it's intact doesn't mean there might be an issue with it, right?
Right.
So from what our perspective, what we're doing is we're trying to see not only is it working or is it not working, but how well is it working? And
Mhm.
then through a battery of tests, then we can figure out which parts of the brain is either firing too high, firing too low, or which circuits of those parts of the brain may be implicated as well. And when you look at it from this perspective, sure, you'll diagnose it as whatever big name diagnosis is most appropriate. But so most of my patient base is post-concussion syndrome. So I can have 15 people with a diagnosis of post-concussion syndrome or a diagnosis of concussion, and all 15 of them can have a completely different issue going on in their brain. One can be an ocular issue, one could be a migraine, one could be a cervicogenic headache, one can be a whiplash with some cervical trunk, so sympathetic issues going on as well. One could be a POTS patient. Like there are so many offshoots that can happen with a traumatic brain injury. And then we even get so one of the clinics that we're involved with, the Lyman Pence Treatment Center in Massachusetts, we're there one day a week. So we see concussions combined with Lyme or some other tick-borne illness. And so the things get a little crazy. And it's good. So in order to fix these things, or at least to improve them or have a chance to improve them, it's not about what therapy I want to provide. It's about what do you as the patient show and what therapies will be most appropriate for what you need.
Yeah.
I think it's a big distinction. It's not about what I think is best. It's about what actually is best for you.
For sure. There's so much to unpack there too, because you hit on so many points. So I'm going to kind of pick them apart, but I want to talk about that one specifically though, because just as like in functional medicine as well, these other specialties, these specializations that have sort of come out of this world of integrative medicine, what I see so often is that people are sort of taking these models, like these protocols, like they're almost wanting to kind of get into the scenario where they don't really have to think anymore. Like they have this patient that's in front of them that has this list of symptoms. Maybe you've pulled these labs and you've seen these things. And so all they want to do is be able to like cut and paste a protocol into that scenario. And I struggle with that so much because sometimes what happens, right, is that like I get this patient in my office and they're like, you do functional medicine. I've already seen a functional medicine physician and it didn't work. And I'm kind of over here like, well, what did they do? Like how did they treat? What did they do? And you start to kind of unravel some of these pieces that it just like, I'm just seeing it more and more often that people it just appears to me, at least on the other side, that I'm seeing a lot of patients that it looks like, they're going into different physicians' offices. I think the same applies sometimes to medical medicine, to allopathic medicine, that you go in, you get a pill, and that's kind of your scenario. And it's starting to change, but it's taking a lot of time, I think. But it's this like cut and paste almost thing that just it's not considering what the actual patient has going on and that it's unique to them. It always is. It's always different.
Think about how medicine works.
Yeah.
And the most important thing to think about is how do you pay for it? The way you pay for it is typically through some sort of insurance model. And insurance is going to say, based on X diagnosis, treatments A, B, or C have been shown to be most effective. We're going to support treatment of the most common etiology of an injury, of a disease process, of a pathophysiological process. And we are going to focus our efforts on the people closest to average.
Yep.
So that way we can have the most wins for our dollar, and for the people who are not average, people who are outliers, we're just going to sort of like look the other direction. But the way this works and the way that healthcare works is, from a patient care perspective, you start off with going to the doctor. The doctor asks you what's going on, so you have all your subjective information. Then they do some sort of exam, or we hope they would do an exam. And then they have objective information. Then your subjective plus your objective, when correlated together, creates a diagnosis. You add up all the positives, you add up all the negatives, and that gives you a title. And then you get rid of all the findings, and you just focus on the title. Now that you have the title of vestibular migraine. Right. Now forget what makes your vestibular migraine different from other people's, which is what we look for in our clinic. Now that you just have your diagnosis, Now you focus on, okay, what are the accepted treatment methods? Or if you go to a certain practitioner, like you can go to an acupuncturist, say what style of acupuncture are they going to do? You can go to massage therapist. What style of muscle work are they going to do? You can go to PT. What style of manual therapy / exercises are they going to do? You go to a chiropractor. What style of adjusting are they going to do? And you can see that you see this pitfall, which is you go to the person picks their treatment based off of what they like to do or what their training is, but they're not anybody can train more. Anybody can learn new things. And
Absolutely.
It seems mind-blowing to a lot of people, but you can always learn more things. And all these people have the opportunity to learn more and provide more information and understand if their therapies that they want to provide or they're trained in providing, if it's actually appropriate, or if it's a situation where you're like, all right, well, I'm just going to keep on going for another 4 months and hope we get better. Oh, sometimes it takes longer. Sometimes it doesn't. I feel like with a better examination, you can figure out sooner if it's going to take longer or not, or if you're just going the wrong direction.
Right.
So with the functional medicine world, and this is something that you and I have talked at length about, which is my biggest, so functional medicine has become its own silo now.
Yeah.
Neurology, in its own respect, has become its own silo now, where you're either focusing on a rehabilitative model, or you're looking at a neurochemical model, or you're looking at a functional medicine metabolic model, but you're still siloing yourself into, okay, well, you have symptom A, B, or C, and no matter what it is, we're going to check to see if you have gluten sensitivity. We're going to check to see if you have dairy. Or they might not even check, and they may just say, okay, well, I'm going to put you through my diet of choice. Right. I once spoke to a health coach who did that famous program out of New York City. And after chatting with her for a little bit, she said, no, all I can do is tell people to drink more water, eat more vegetables, eat less sugar, less refined foods. And then I just put people on a juice fast when they're ready for it. And then the question is that doing what's necessary for the patient? There's other programs out there that teach a little more about like laboratory analysis, but at the same time, if you're not doing a physical exam, how do you know that any of those lab values that you're looking at correlate at all to the patient's subjective complaint or their objective findings? Because just because you have, maybe you have iron running a little too high, or maybe you have your lipids running a little too high, that could be genetic. You could just run high with those things. Your average for your genetics could be different than what they're looking for. And if you're not having any of the other things that are visibly seen on physical exam, is that really worth the patient's money to get sort of a half answer? Or
totally.
It's sort of like, let's figure out how quickly we can get to something where we can go on autopilot.
Oh, 100%. 100%. The other thing too that I wanted to talk about too is that when we kind of get suctioned into this silo, right, where we just kind of sit in this world, because it can get really hard, right? When you get into any of these worlds, there's a lot to learn. There's a lot to know. There's a lot of different people doing a lot of different things. So I end up finding myself just kind of ending up in the functional medicine world a lot, because there's a lot to learn. There's lots of new research coming out. There's lots of new topics. There's lots of new, just different physicians talking about different things, so like, for example, right now, something that's really going around a lot is circadian rhythm, and trying to figure out a little bit more about that. It just happens to be a topic that's kind of on the top of things. There's some new research coming out about it. So I've been, kind of sucked into that world, but at the same time, and I don't know if you know this or not, but I actually did take one of the master's courses for the Carrick Institute, which is for functional neurology. It's before I actually found functional medicine. And then they moved all the courses over to the East Coast. And I was like, well, that's too bad. I'll have to do that later. But I wanted to get my before I went to chiropractic school, I was on the track to get my PhD in neuroscience and do all of that. And I just ended up changing courses because you've talked about this many times on this podcast already, or this video already, but I get migraines, or I used to get migraines. And so I found a chiropractor that started my journey to getting over migraines. And so then that's what kind of dragged me into chiropractic, and I went that route because I found that to be really, really helpful. More of a hands-on approach, right, than what usually people with PhDs in neuroscience do, which is maybe work in a lab with a lot of rats. So anyway, but the point being though, that I think it can be really hard to reach out to different places and start gaining more information in different areas. Hard, but still necessary, just because there's always so much to learn. That might just be me, that I'm always interested in what can I do to help my patients better, but I don't know.
When it comes to functional neurology or functional medicine, if it sounds simple, then you're probably missing a couple parts.
Yeah.
And we didn't even talk too much about what functional neurology does from a perspective of like so we know like what kind of patients I see, basically anything that has to do with the brain. In our clinic, we blend functional neurology and functional medicine, especially over the brain-gut axis, to try and get results as quickly as possible for the patient. Terrible business model when you're talking about that. The more successful you are, the patients leave, which is what we focus on, is actually our goal here at our business. Yeah. But from a functional neurological model, we use a rehabilitative aspect to create activation in certain parts of the brain, like through the examination that may not be showing too much, or we use them to slow down certain parts to create control over certain parts of the brain.
Right.
Think of anxiety. It's the frontal lobe running away. It could be caused from the top of the brainstem, your midbrain running away, which could be caused from your cerebellum running away. And so we have to evaluate for all those individual aspects and come up with an appropriate plan, usually through a lot of trial and error. We do a test, we see what happens. We do a therapy, we remeasure our test, we see what happens. And we can wiggle our way and fine-tune our way to the most appropriate therapies for the brain that we're working with. And then at the same time, we can support nutritionally, and we can use a biochemical-based functional medicine model to really target what's going on with the patient. And I don't even like using the word holistic, because anybody that you can make holistic mean anything, which at this point means nothing. And same thing so I like to say we do a comprehensive and thorough approach, because we actually do.
Yeah, no, I think that's really the lingo, the copy, like all the words that are used at this point are sometimes, at one point they meant something, but they don't necessarily mean anything anymore.
Nope.
Yeah. So one of the things about migraines that always intrigues me is because I personally suffered from migraines. And one of the things that I did when I got one of my migraines right after school is I went and saw a functional neurologist here in Portland. And one of the things that they did was they put me on one of those soft pads that you stand on. They had me so they were looking for a vestibular migraine, but so they had me close my eyes and then kind of bring my head down and bring my head up and move it all sorts of different ways. And they were
looking for more than just vestibular with that.
Okay. Oh, well then let's dive into that. But so anyway, so they were watching I'm assuming they were watching as I was kind of moving and kind of teetering back and forth, because there were a couple points where I kind of lost a little bit more of my balance. I had to kind of open my eyes. And what they ended up doing to treat was they did the Eppley Maneuver which I'd learned in school, and I was like, how about that? But anyway, so they did that for me because it had something to do with my inner ear. But anyway, we want to expand on that a little bit because I'm personally very interested in that.
The Romberg test. So classically, a Romberg test is you have them put their feet together, and then you have them stand with their arms at their side, and then you have them close their eyes, and you're looking to see if they fall to the ground. That's positive. You can tease it out a little more. If they fall to the ground in a smooth way versus if they fall to the ground in a real jerky motion, can tell you about what's going on more, if it's more cerebellar or cortical. But at the same time, they're still looking to see, do you fall to the ground as a dorsal column system, just your sensory information from your legs or your trunk isn't working. But you can fine tune this test to get more appreciable data from different parts of your inner ear. So to start off, if you're on flat ground, what you can do is you can turn your head to the side for more right horizontal canal stimulus. You can turn your head to the other side for left horizontal canal stimulus. You can turn to the side and lean back for a posterior canal, lean forward for an anterior canal.
Mm-hmm.
You can have them have their head in a certain position, and you can tease out what that means more for each individual canal in the ear.
Sure.
You can then put them on a foam pad, which reduces proprioceptive information coming from the legs. Say, okay, well, how do you respond when we reduce proprioceptive information and we take your inner ear out of orbit? So your horizontal canal, we're going to make it go like this, so you get weird information. And we have you close your eyes, so we're going to reduce visual input. So now you're basically using really altered somatosensory stimulus and really altered vestibular information to see how well can you handle it.
Yep.
But you can also do something where you have them look up and you are changing cervical motion, right?
Mm-hmm.
You can check to see if it's vestibular, you can isolate exactly which canal is the issue. Or if it's cervicogenic, you can then see, does this make it worse? And then you can do ancillary tests. You can do associated tests afterwards to further go into a direction to pinpoint, is it a neck thing? Is it a vestibular thing? Is it a muscles and joints thing? How much of it is each? Because and most likely it's probably some combination of them.
Right.
And how do they interact? And then also you can use therapies on that foam pad to say, okay, we know what your baseline is today,
Mm-hmm.
right now,
Mm-hmm.
because your baseline will change every day based off of maybe you're having a good day, maybe you're having a bad day.
Literally anything.
Really? Yeah. And so
Yeah.
now you have your baseline. Now we can do therapies in a controlled environment, or at least a more controlled environment. And we have an idea if we're actually going in the right direction, because your balance will change in real time.
Yeah.
It's pretty
So
cool.
It's really, really cool. So do you guys apply some of those similar things to when you see concussions as well?
100%. Because a
Yeah.
concussion, when it comes to the brain, it's all shades of gray.
Right.
You may have it's easier, it's more difficult to work through these, but it makes more sense to think of everything as one big spectrum, from neurodevelopmental to neurodegenerative to some sort of traumatic, creating a change in there. And it's one big spectrum, and you got to figure out where on the spectrum they live. They could have a little bit of Parkinsonian issues that just aren't happening yet, but that can give you a window into what may be happening physiologically before they're officially diagnosable with Parkinson's.
Mm-hmm.
And it gives you an idea of what kind of treatments you can try doing, and maybe you can help, if it is a degenerative condition, slow it down before it even becomes an issue. If it's not degenerative and it is a traumatic condition, then you have an idea of how to rehabilitate it. And so there's a number of different ways, and I just say it's brain. We work on the brain.
Sure. Yeah. Well, yeah, I love that. So one of the things too that we actually discussed, I sent you over a paper a bit ago, like a while ago, but it was talking about the connection between they're starting to explore more between the connection and the axis of the gut-brain axis. And one of the things they were looking at were some of the changes that can happen with when you get a concussion that can happen with the brain, but they can also change things that are happening in the gut. So, and I know there's a lot more that we're starting to learn about just the GI tract as a whole, but I thought that was so interesting because a trauma that can happen somewhere on the body is also affecting a different place as well. And as you mentioned, I mean, when you started talking about anxiety, one of the things that I work with people on my side is looking into where some of those inflammatory pieces can be coming from, because anxiety and depression can be coming from a bit of increased inflammation in the body. And so starting to look a little bit deeper into what's happening elsewhere, which you guys do in your clinic, if you're pairing both functional medicine and functional neurology together and looking at that whole system, you're kind of taking it from both sides, which is really, really, really neat. It's a good
And the question is, let's dive into this a little bit. So if we're going to be talking about anxiety as an inflammatory process, when there is increased inflammation, is there always anxiety?
Yeah, no, not always. Right. It's
Right.
very patient.
It's
Yeah,
very
go ahead.
patient specific, but if we're
Right.
going to be from a clinical mind, we're going to look at it and we're going to say, okay, well, what's different in this patient that's different than that patient? Do they
Mm-hmm.
have the same anxiety if they both have anxiety? Is
Right.
one anxiety more nervousness, and does it lead to depression that's more associated with guilt versus a depression that's like psychomotor fatigue versus a cognitive fatigue?
Mm-hmm.
What we want to do is we can actually figure out where in the brain that inflammation is just by doing a good exam and just by asking the right questions. So to make it straightforward and simple, the have you heard of central sensitization?
Oh, yeah. Yes.
So central
Right.
sensitization is when you fire a pathway repeatedly, that pathway becomes more efficient.
Right.
And what could happen uh, is, you know what? Do we have a couple minutes where I can draw some stuff to help your people learn?
Sure, if you'd like. Go for it.
You let me share my screen. Central sensitization, like that is a huge cup.
Mm-hmm. It
Wow.
is. It's just tea, though.
I am surprised you're not vibrating and shaking like one of those
It's not coffee.
we're working on.
Nope.
Okay, so we're going to talk about central sensitization.
Awesome.
And you've seen this before.
Mm-hmm.
So this is time and this is millivolts. So you know that that's what a neuron fires like, right? You
Right.
get your activation energy, it fires, you get your refractory period, then it comes down. Maybe it's a little bit, not to scale, of course. As you fire a neuron more, it's going to become more efficient. So in the same amount of time, you'll have three fires instead of two.
Right.
So then the question is, what do you need to fire a neuron? You need oxygen and you need glucose. Those things can run out, right?
Right.
A certain amount that you use and it can run out quicker.
Mm-hmm.
So how do you get oxygen and glucose?
Breathing, eating.
Breathing. And how does it get to the brain?
Through your blood.
Blood supply. So if your blood supply is being measured, what kind of testing would you do? Probably an fMRI.
Yep.
What are they measuring? They're measuring to basically see the activity of the brain. And the activity of the brain is based on which areas are receiving more blood supply. You only have so much blood supply that can go around. So other areas that aren't as efficient with it, or other areas are going to receive less blood supply. If they're less efficient with how they use blood supply, then you may see some deficits. Okay, so let's go back to that central sensitization issue. So we have one part of the brain that is firing a little bit higher. It
Mm-hmm.
ran out of nutrients, so now you see a decrease in activation. What does that look like?
I
Sustainable
mean,
high
that can look like a lot
firing
of things.
is going to
Yeah.
look like anxiety
Mm-hmm.
or nervousness. And this depressive
Depression.
is going to
Yeah.
look like depression. We're not talking about clinical depression. We're just
Yeah.
talking about the building blocks of it, like
Yeah.
some
Yeah.
sadness, some
Right.
slower movement. But when we see depression like this, we start to see more than just, like when it's true depression, you don't see, oh, I'm sad today. You see like a complete loss of function. Like their face just droops. They just can't motivate themselves to do anything. They are sitting in this world with no motivation, no facial expression, and they are just tired and their brain is just tank.
Yeah. Right.
So you have probably worked with people who have had energy-linked excitotoxicity before, right?
Yeah. Yeah, for sure.
For people who don't know what that means or what that is, energy-linked excitotoxicity means that when you have a neuron, this is a cell body, and then these are just all these little connections from the neuron. So this is going to be like the cell nucleus, right? When you get activation saying, hey, you should fire, once you receive enough information to fire, then it's going to send an action potential down the trunk, down the axon,
Mm-hmm.
and to connect to another neuron. But if you're in this stage where it's just firing too high, you're going to reach a point where this neuron becomes anaerobic, which means just like in muscles, you go past your oxygen and you go to your lactic acid pathway. But your lactic acid pathway in the brain kind of sucks. So it's going to actually cause excitotoxicity of the cell.
Mm-hmm.
And the cell is going to, without scaring people, it just means that this cell is going to cook and no longer function, and other neurons near it are going to have to take over. All right. Within this energy-linked excitotoxic story, once you have a loss of a neuron, now you have less neurons able to handle load and less neurons firing, so that's why you have that true depression, that true just sluggishness.
Yeah.
So what are things that can change this activation level? So this is supposedly -70
Right.
in a book, but
Right.
we know that this level can go up or down depending on certain things. So it can go up to the threshold that it needs to fire by being less negative, right?
Yeah. Right.
Are proteins positive or negative?
Oh, don't ask me these kind of questions. No, I'm just kidding. Proteins are positive, aren't they?
Proteins are negative.
They're negative.
And
Okay. Well, here we go.
the larger the protein, the more negative they are. So in other words, the larger the neuron, the more negative that neuron is sitting, the less it takes to trigger it. So think about you're in the ocean, you've got a blue whale swimming, and you've got a bunch of dolphins and other fish around it. If something swims by or a boat comes at it, all the little fish are going to scurry out of the way, but the whale's just going to be, you're going to bump into the whale, and the whale's just going to be like,
yeah, right.
It's not going to care. It takes a lot more energy to make that blue whale move than it takes for the tiny fish to move.
Mm-hmm.
So the smaller the neuron, the less negative it is, the more likely it's going to fire on a hair trigger.
Right.
Right?
Right.
However, what kind of things can make this -55 lower?
Well, it's usually looking at your sodium potassium channels, isn't it?
Yeah, and what affects those?
Well, inflammation right there. You got it.
Raised levels of cytokines, like interleukin.
Yeah, interleukins, interleukin 4, 10.
Like those are major ones.
NF-kappa beta, killer cell. Oh, well, there's a lot of them.
Well, NF-kappa beta is kappa B is actually a pathway, not
it is a pathway. You're right.
And these all.
I meant TNF alpha. That's definitely what I meant.
Of course.
Yep. There you go.
So NF-kappa B.
Mm-hmm.
And those all fire that. When this is firing, that's when you get inflammation. And when this happens, then this lowers, which means you need less energy to fire. So you push that central sensitization pathway more.
Yep.
Pretty easy.
Mm-hmm.
So what does that mean? It means that you can push neurons beyond what they can handle, and then you get anxiety. So when you're looking at the brain, you're going to get anxiety. So if this area fires to, let's say, your hypothalamus, and it also fires to your frontal lobe, where the areas of your frontal lobe that can't handle as much information coming from your cerebellum or your brainstem is going to be the parts of the brain that you see deficits in or symptoms in. So you can correlate symptoms to parts of the brain associated with what they're complaining of. And then you can have an idea of what do I need to do to fix that area? Can I do it metabolically? Can I do it with a rehabilitative model? Do I need to do both? The other thing to think about here is we're going to go to the hypothalamus, which that's going to be the hypothalamus. Let me do that. So this is your hypothalamus.
Yep.
So you get information from your eyes, firing in through RGCs, reticulogeniculate cells. They go from the retina to the geniculate ganglion.
Yep.
you also have light information going to your suprachiasmatic nucleus. And you've already mentioned once today the circadian rhythm. Why you've been looking at that?
Yeah.
Why do people typically look at their circadian rhythm?
Well, mostly because they're usually looking for either they're not being able to sleep, right? So their cortisol and their melatonin levels are just completely wonky. So they, decrease sleep, so decrease energy. People are feeling like they're super stressed out, right? And they're just, or they, or there's a lot of them. But they, like, I also see people who feel like their adrenals just are not functioning anymore. So they just feel like they have this like super duper low cortisol that they can't, like they're not recovering well. They're, I already mentioned like decreased sleep, decreased energy, and stuff like that.
So sleep, we're going to draw a couple of brain structures out here, but there is a loop that is involved with your circadian rhythm called the circuit of Pepez. And I highly recommend reading a lot about the individual structures in it, because you may start thinking that it less has to do with the adrenals than it does have to do with brain structures that fire down to the adrenals. So when you talk about the hypothalamus pituitary adrenal axis,
Yep.
when you focus on this, you're missing 2/3 of it, at least.
Yes, totally.
So one thing to do is to look up this. When you look up that and you look up the individual structures and you start learning about what they do, then it makes it a little more interesting where you're like, oh, now we can see some cause and effect. Other than your adrenals are tired, we need to wake your adrenals up, which may be a cute story and all, but it might be missing part of the problem depending on the patient, of course.
Yeah, absolutely.
So if we're looking at this, and we're looking at this, so I find a lot of patients that have decreased sleep, and I'm working with one patient right now.
Yeah.
There's two halves of sleep. There is can't fall asleep, and then you also have can't stay asleep.
Yes. And I would say percentage wise, I probably see like maybe 20 or 30% are can't fall asleep, but the majority of them, like 60-70%, are can't stay asleep.
So when they say they can't stay asleep, what time do they usually wake up?
It depends. Sometimes if they've gone to bed, let's say at around like 8 or 9, they'll sometimes say that they're waking up around 11 to 12. Some of them wake up at like 2 to 3 a.m. And then some of them are like, they wake up multiple times a night. Sometimes they'll wake up at like 4 or 5 a.m. and then just, that's it. Like they cannot get back to sleep from there. The part of that too, though, can be some of them are waking up because they need to go to the bathroom in the middle of the night. So that's a whole other like issue right there. But so that's a couple of it.
Do any of them wake up in a sweat?
Yeah, some of them do, especially if they're around menopause-ish time.
Mm-hmm.
So working with hormones and stuff like that.
Yeah. So let's talk about these.
Yeah.
So to make it quick and easy, blue light creates cortisol, which during like in the morning, 7 a.m., it starts to climb up, or it starts climbing up around like 4 to 5 a.m.
Yeah.
And then it wakes you up, and then it stays up here and it starts going down in the afternoon. And then your melatonin is going to be higher, and then it's going to lower down as this cortisol gets up. And so you have this diurnal rhythm where cortisol and melatonin are opposite from each other. So when we are looking at this, one of the things that we want to think about is what's their cortisol doing? Before we start going with, so when it comes to falling asleep, I highly recommend not jumping to GABA first unless you're using it as a test. Like we all know that GABA is too big of a molecule to get through the blood-brain barrier. So if anybody gives you GABA and it works and it does anything. If it ramps you up or makes you tired, there's a different problem to do that you have to take care of.
Mm-hmm.
There's also something that people don't really understand is when you have neuron A firing into neuron B, firing into neuron C, they're still firing when they have GABA. GABA is not inhibitory where it stops cellular activity. GABA activates cellular activity in an inhibitory function on the next neuron. So it's stimulation of inhibition.
Right.
So there was one person I saw on Facebook saying that, okay, I have a patient with really high glutamate from your urinary neurotransmitter test, which bupkis anyway. Neurotransmitters measured in urine are really the least clinical useful thing ever. Just because you don't know if it's coming from the brain, you don't know if it's coming from the gut, you don't know if it's a clearance issue, and you don't even know if you're getting a good measurement because there is a little bit of monoamine breakdown in the kidneys. So I don't think it's worth spending any patient's money on. There are some cases that I used it on and it was helpful, but that was more like a last ditch effort. Like we have no idea what's going on, and we were able to get a little bit of reduced symptomatology.
Yeah.
But you don't want to use GABA to counteract glutamate because remember it was Witter ions from biochemistry?
Oh, yeah.
Remember how glutamate and GABA both can convert readily and easily from one to another?
Right.
So you think about an area that's trying to push GABA versus an area that's trying to push glutamate. If your brain is trying to push more glutamate for a reason, it's going to take GABA and push glutamate.
Sure. So you're just basically, if you're putting GABA into the system, you're just basically increasing that pathway.
Yeah. No matter what,
Yeah.
like you can give GABA for all the best intentions, but you're basically saying,
Yeah.
hey body, we know what you're trying to do. We're going to pretend to not know how this works. And we're going to give you more of what you want to make symptoms worse.
Mm-hmm.
All right. So falling asleep, we know reducing blue light. Why do we want to reduce blue light? So that pathway from your eye to the hypothalamus is not firing as high. So a good test to see if you're receiving any sort of blue light, or if you have all the colors combined together and in the form of light, what color does it look like?
Like white?
Yeah, it's
Right?
white light.
Yeah, it's like
Yeah.
white light. Very, very white.
Very
Usually.
white. So if you take
Very
your
white.
phone, even if it has the blue light thing on it, so that you're
Yeah.
like in the yellows and you hold it against a wall, you'll notice there's still white light coming out of it.
Mm-hmm.
So
Yes.
the only thing that I really recommend and I've seen effective for my patients is there's these goggles you can get on Amazon called the Uvex Skypers,
Okay.
and they're like under $10.
Yeah.
You grab a pair of those and you put them on. Now, one of the things that we can think about is light stimulus and translucency of cells. If you
Right.
close your eyes, can you still see light?
Yeah.
So I have patients when they like need an afternoon nap because they just can't make it throughout a day. I'm like, put these goggles on anytime you close your eyes. Because light is still going to come through there, and light is still going to be stimulating your ascending reticular activating system, which
Right.
is still going to be pushing cortisol.
Yeah.
And then if you're still pushing cortisol, you're still creating the same problem. So
Right.
here's the fun part. And I know I've been talking a lot.
No, I love this. This is fantastic.
So urination,
Yeah.
what part of the nervous system regulates urination or your micturition responses?
Parasympathetic.
Right.
Right? That's what you're going after, right?
Exactly. You're on point,
Yeah.
like usual.
It's-
So it's your autonomics.
Yeah.
And if you have changes in your autonomic system, it may create more urine than you need to. And I'm not saying you can stop a person from urinating, especially if they're trying to stay hydrated or stuff like that.
Yeah, I think that's probably the hardest one, is that people know now that they need to be drinking a lot of water. That in order to drink a lot of water, you're going to probably be going to the bathroom quite a bit too. So it can be a
You
little
should be
bit.
able to wake up, pee, and go right back to sleep.
Right.
You shouldn't be up for a couple hours or something.
Yeah, no, totally.
But we know that this is autonomic. What about diaphoresis? What is that? What is sweating?
That one's more sympathetic.
Yeah.
Usually. So for
Autonomic.
anybody listening, parasympathetic is going to be your rest and digest. Sympathetic is going to be more like you're running from a lion type thing, where, yeah, you're just very fight or flight. It's going to be kind of very stimulated in a way. There you go. Perfect.
Yeah. So when you're looking at these two systems, you see there's a lot of autonomic stuff going on. And when people wake up in the middle of the night, there's autonomic stuff going on. So let's map this out just a little bit. And if we're talking about autonomics in the middle of the night, what are autonomics going to drive? What are the same area? So in your brainstem,
right?
The same area that creates that you get autonomics driving from is also going to drive catecholamines. So what ends up happening with patients is they push through their cortisol. They're pushing through this, they get through that pathway, and now they run out of cortisol. And so they were producing cortisol the whole time, which has been pushing hypothalamic pathways, which also pushes other hormones, which means if you see some hormone dysregulation, potentially, so the way neurons work is there is some scatter of activation local to it. So if you have activation of cortisol releasing hormone, you're also going to have activation of the other things adjacent to it. So you can have hormonal dysregulation not due to an absence of playing with their hormones.
Sure.
You know what I mean? The same way people don't have a Prozac deficiency, they don't have an issue. Like not everybody has a hormone deficiency unless they actually do, of course.
Yeah, right.
So what happens when you push through your cortisol? You're going to start pushing through your catecholamines. What are two major catecholamines?
Oh yeah, epinephrine and norepinephrine.
Yep.
Which also, just so you guys know, so cortisol is generated by your adrenals, but so is epinephrine and norepinephrine. There's just two different layers inside of the adrenals that basically create these things and then push them out. Just so you know.
Caveat to that, though.
Oh, please. Add to it.
Cortisol is coming. Cortisol comes from your adrenals. Epinephrine and norepinephrine peripherally is different from the places that epinephrine and norepinephrine are created in the brain.
In the brain, right.
If you have an intact blood-brain barrier, then these should not affect it as much from coming from the adrenals as much as the epinephrine, norepinephrine that come from the brainstem.
Right.
So,
cool.
That is a caveat because I keep reading articles or blog posts from people talking about there's most of your serotonin is made in the gut. And I'm like, well, your serotonin, if it is made in the gut as 5-HT, can't actually get into the brain. So who cares?
Yeah. Oh, okay. We'll come back to that in a second, but okay. So go ahead, keep going.
Okay. So as you start pushing through these cortisol pathways into these epinephrine and norepinephrine pathways, then you'll have sympathetic effects also associated. So if cortisol wakes you up, do you have sympathetic effects?
Yeah. I would think so.
Not as much.
Not as much.
If you wake up due to cortisol, you shouldn't be having like sympathetic pathophysiology. Like you shouldn't wake up in the morning, right? Right. You should wake up and be awake, and you should have sympathetic effects like your ascending reticular activating system saying, "Hey, wake up! It's another day. Be excited, happy, and cheerful." Yeah. But if you have epinephrine and norepinephrine waking you up, then you're going to have other things that epinephrine and norepinephrine are going to drive: sweating, micturition changes, things like that. Headaches. Do you ever wake up with a headache?
Sometimes.
So, or the collective you as in
so I do sometimes, not often, but yes.
But
yeah.
Typically, depending on when they go to bed, what happens is they use up all their glucose. They don't have stable blood sugar. So as they use up their glucose, then they start using cortisol to fire mobilization of glycogen and potential, not really fat stores, but typically glycogen. Cortisol will create glucose release from your glycogen, and you'll use that. Yep. And then as you continue to do that, because you can't stabilize your own blood sugar, you will then chew through that cortisol pathway to then chew through your epinephrine, norepinephrine pathway, and then you have the problems. Yeah. So the goal is, how do we stay in that cortisol world and not get to that epinephrine, norepinephrine world. And I mean, if it was easy, I'd be a millionaire. It's not
Mm-hmm.
easy, and everybody's
Mm-hmm.
different.
Mm-hmm.
However, there are certain supplements that I usually recommend. One is acetylserine.
Okay.
What this does is it increases the half-life of cortisol. But no, wait, don't we have too much cortisol? Why do we want to make the cortisol last longer? We want cortisol to last longer so there's more cortisol floating around so your body doesn't think it has to make it.
Mm-hmm.
So you don't use as much of the pathway.
Right.
Phosphatidylserine and whatever product you find that in is going to be very helpful for your circadian rhythm and modulating that. What else can you do? Nutritional stuff. I had a patient while I was in chiropractic school who was waking up with headaches every day, and you know what fixed it? I just said, eat half an apple before you go to bed every night. No more headache.
What's the component in apples then?
Pectin. Slows gastric emptying.
Oh, yeah. Okay.
Yeah. I mean, you can use animal protein for that. That will also
Sure.
emptying.
Yeah,
I like pectin, and I like because I knew that if he ate the apple, he was going to have the fiber from the apple and the sugar molecule within it. So I wanted it to be as slow a release as possible.
Yeah.
You know, wanted to feel like bloated from having some meat before bed.
Right.
He also had some other stuff going on, which was highly interesting to work with as well.
Yeah.
But
Okay.
yeah, so that is a lot of times that will take care of a chunk of it, or at least get them sleeping better.
Right. Okay, so awesome. The other follow-up question I had to that, because I've been looking into some more research too about the blood-brain barrier and this concept. So just as you mentioned, so norepinephrine, epinephrine being in the systemic system, and then having other stuff happening up in the brain and it generating its own things. Also, tying in here to what you just said about, we have the same neurotransmitters that are in the gut that are also in the brain, but they just have different sources from where they're being made and where they're coming from. But one of the things that's interesting that I've been looking into, that connection between like a kind of a leaky blood-brain barrier and some research that's looking into a connection to leaky gut and the similarities between the two. Was that somewhat what you were alluding to, in a sense, that if you are seeing some of these things in the brain that, or in the systemic system, that they're supposed to be disconnect, like there's supposed to be a barrier between the two? Is that sort of what, well, let me refine my question here. Have you looked into some of the research between leaky, so this intestinal permeability with the kind of like this leaky blood-brain barrier piece that they're talking about?
What does intestinal permeability look like?
So what it looks like is, if you if you have like two cells together, they have tight junctions between the two, and one of the things that can happen is with inflammation of that lining, the cells can start, and especially for particular people who are gluten sensitive, and if that, basically those cells release zonulin, which creates an inflammatory response in the gut, and then those cells start to get a little bit loose. And I'm just explaining this for people who also are watching, but so when food comes through the GI tract, if you have leaky gut, food is supposed to get broken down into your smallest pieces, right? Like amino acids, vitamins, minerals, that kind of stuff. You have proteins that are supposed to take that particle through the cell and then into the bloodstream, where it then gets used. The problem, though, is that if those cells get a little bit leaky, you don't have physical holes in your gut. There's particles that can make their way in between. And then if they're not broken down completely, that's where you start to have some problems. So this idea of like an inflammatory response, yep, thank you for drawing that out for me. This kind of inflammatory piece that causes this gap. It's not a gap. It's just a little bit loose. Thank you. That's it right there.
So I was actually drawing something different, but I did want to humor you. So
thank you. I appreciate it.
I was a geology major in undergrad,
Yeah.
physical science major. here's an example that we used in our stratigraphy class, in our sedimentology classes. It's a study of sediment and how it creates layers in the earth. If you have a bucket full of bowling balls versus a bucket full of marbles, and I'm not going to draw it all the way up, that's a lot of marbles. And we put a cap on it, which bucket has more air in it?
Oh, this is one of those questions. You would usually say you would think to say the one on the left with the smaller marbles, but a lot of that depends on mass, doesn't it? On how much is in there. And would it technically be the same?
Doesn't depend on mass, it depends on the shape of the object.
Yeah.
So the shape of the objects are the same shape, round,
Yeah.
spheres,
Around. Mm-hmm. Spheres. Yes, they're circles.
Sphere is what you put on a bagel.
Yeah.
All right. So
Okay.
the answer is they're the same.
Yeah, right.
They have the same amount of air in there.
Mm-hmm.
However, because of the shape and because of the size, the gaps of air here are going to be bigger than the gaps of air here.
Mm-hmm.
So, cells are living things. When cells become inflamed due to an autoimmune issue or due to an infection or due to decreased vagus nerve tone into the endothelial cells, that would it decreases the integrity of the cell wall. What happens is cells go from being one size and they swell.
Yep.
Now that they've swollen, the gaps in between the cells must be larger.
Right.
Because there is going to be more gaps. It is going to be, because they are the same shape still. They are still the same shape of cell.
Mm-hmm.
So there are now going to be gaps. That's where leaky gut or intestinal permeability, or whatever you want to call it, comes from.
Yep. Right.
Inflammation of these cells.
Right.
Reducing the inflammation is going to then bring it back towards the normal healthy size.
Mm-hmm.
Which, when we look at this, and I apologize, I am having a brain fart right now. There are 3 types of immune cells in the brain: astroglia, microglia, and oligodendrocytes. I know it's not microglia off the top of my head. It's either astroglia or oligodendrocytes. Those are the blood-brain barrier cells.
Mm-hmm.
So there's inflammation associated with, and I'm pretty sure it's astroglia, but if there's blood-brain barrier inflammation associated with your astroglia making these bigger, then you're going to have a change in the permeability of the blood-brain barrier. So what do you do about it? You have to reduce whatever is creating that excessive inflammation.
Yeah, right.
This is why when we work with our concussion patients, like, you can go on any blog and you start seeing, oh, all concussions need vitamin C. All concussions need vitamin D. Oh, they need carnitine. They need XYZ. They need, studies show that if you give supplement X, concussions get better. But we find in our clinic that if we just use a combination of turmeric, specifically, actually, I'm going to rewrite that because I don't want people thinking that you can just eat the root and that'll
Yeah, and we can talk about that. Yeah, okay. Mm-hmm.
resveratrol,
Mm-hmm.
and then DHA. We use some combination of these 3, and we might add
Sure.
like an additional EPA-based fish oil. We may
Yep.
add a couple of extra anti-inflammatories or vitamin D or K2D or some magnesium, like magnesium L-threonate
Yep.
or magnesium glycinate, depending on what's going on with the patient. It's all different, of course. Every concussion is different. But
Mm-hmm.
that's why these first 3 that act as centrally acting anti-inflammatories, we find that to be even more helpful because a concussion is a problem of connectivity in the brain,
Sure.
and inflammation associated with that disconnectivity. So if you reduce the inflammation, now the neurons can work better, and now we can potentially exercise them to get them back to where they were before, or at least to a point where they won't have symptoms.
Yeah. Yeah, that's awesome. One of the things too that when it might have been, was it last year? My dad suffered a pretty bad concussion, and one of the things we talked about was how, I have a tendency to want to just throw so I think a lot of people, right, have this tendency to want to throw anti-inflammatories at a lot of things just right off the bat. But one of the things with concussions you don't want to do in some cases, which you can correct me,
No,
but you don't want to throw anti-inflammatories at that right off the bat. Did I get that correct?
you are 100% right,
Yeah.
because you want the damage and the inflammatory process to occur.
Yeah.
Inflammation has a purpose. It's not
Yes.
the root of all evil like some health coaching classes are teaching.
Yes. Yes.
They,
Yes.
it's kind of ridiculous. The
Yeah.
inflammation is appropriate. The thing that goes bad is when inflammation is excessive, or
Hmm.
inflammation is uncontrolled for too long. If microglia are ramified long term,
Right.
what our goal is our goal is to control the inflammation and have it work effectively. So if you had a cell, that's a cell.
Okay. Oh, nice. You're going to draw all the components. My patients get drawings like this all the time in practice. It's awesome.
I
I
think
love
it's
it.
fun.
And
So
I think it's fun too.
so we have the cell. Here's a vacuole. This is the
Oh
nucleus.
yeah, you can draw the mitochondria, all
I
those
mean,
fun
the
things.
vacuole is where all those reactive oxygen species are actually supposed to be used.
Yeah,
They're not
right.
that either,
Mm-hmm.
but mitochondria.
Oh heck yeah. And all those fun things.
All right, so all the fun things.
Yep.
So actually, thanks for reminding me to draw mitochondria, because I needed this for this example.
Yeah, see, there you go. I know.
So inside your cytosol,
Yeah.
the fluid in here,
Yes.
or inside the mitochondria, you have cellular processes that remove garbage, right?
Right.
You have autophagy
Mm-hmm.
and you have mitophagy. And you've heard of beta amyloid, and you've heard of
Yes.
alpha synuclein.
Yeah. Yeah.
So when you're looking at these, different garbage is going to be located more or less in different parts of the cell, depending on where the garbage is deposited.
Mm-hmm.
The diseases that are associated with these are usually a failure of autophagy or a failure of mitophagy.
Right.
If you give inflammation blocking supplements to a cell that is currently undergoing inflammation, you may block the garbage removal process, which is going to be counterproductive.
For
And what we
sure.
want to do with this is we want to then say, okay, what can we do that's going to support this person to make sure that maybe as the garbage is being made, it's getting cleared out appropriately without giving them a supplement that may turn off the system or affect the system negatively. The goal would be maybe some sort of intermittent fasting, like a 5-2 diet like we learned at UWS, or you can
Sure.
give them like an 18-hour fast every 3 to 4 days, where you eat dinner the night before, you wake up in the morning, you take whatever medication, vitamins you need, brush your teeth so you don't smell weird, and then you have breakfast at like 2 o'clock the next day or whatever.
Sure.
So you can have those would be more appropriate strategies. Now, at the same time, if you're having a chronic inflammatory issue, or you're having an acute inflammatory issue as a concussion,
Mm-hmm.
giving them a process like intermittent fasting may be too much too soon for a brain that's currently trying to figure out which way's up.
Totally.
So the best thing to do for a concussion is to do some mild exercise, so your brain gets stimulation and gets movement. Maybe sometimes we will see and we will do vestibular rehab or visual rehab as appropriate for the patients, because we can see when we're fatiguing them out, and hopefully we stop before that. And we also want to get to a point where we can get them exercising and on their own, because I mean, the Buffalo Concussion Treadmill Test, or the Buffalo Concussion Bike Test by Dr. Letty over at University of Buffalo, exercise is good for concussions, but it's about when and where, and does it correlate with your physical exam, and so that we use it appropriately.
Right.
So all the people, like, I mean, I read blogs online that are like, or I get blogs sent to me by patients who are asking questions, and I always encourage that, because I'd rather them ask me the question than try to use Google to and get
Yeah.
someone who really is uneducated in concussion and just thinks they have a good idea. We try to say, hey, look, just do some light movement, do like 5 to 10, 15% of what you normally do to start. We'll do some rehab in office so that we can keep an eye on you and make sure that you're not getting worse quickly. Like there's no slow growing brain bleed or something like
Right.
that.
Yes.
And with constant monitoring, which we'll do, then after about 2 to 3 weeks, then we will do supplements. Now, here's the thing though. 90% of concussions self-resolve in 2 weeks. Do they need to be on supplements? Do they need to pay for supplements right from the get-go? I mean, no.
Arguably, no.
Arguably. Right. However, if you have a patient, they have other things going on, then maybe you might want to hold off on some of the anti-inflammatories, let the brain sort of take care of itself and push that inflammatory process. And then maybe start in a couple weeks if they have other symptoms that are associated, like they also have headaches or they have had some mood changes or something like that.
Sure.
Just because they feel better doesn't mean you don't have changes in the brain, because that connectivity has to happen again. So getting it evaluated and getting checked out. I've had some patients come to me and I've done an eval. I'm like, yeah, you're good. You should like just do a good ramp up, do a great return to play program, even though you still feel fine, just to make sure that you can push yourself before you go back to sport. But yeah, that's sort of how we approach it in our clinic.
That's awesome. That was really, really helpful. I know that, kind of just wrapping it back to what we talked about in the beginning, is just every single patient's different and there's always so much to know and so much to learn. So I think it's really important to know that there are so many different types of practitioners that are out there that specialize in lots of different things. This is a very, very good example of one of those things, concussions, neurological type things. There are people out there that this is what you do. Like, this is exactly what you do. And you deal with this a lot. And I think the benefit of this is, as we've sort of demonstrated through this whole thing, is why it's so important to be taking a very unique approach to every single unique patient. So that's really awesome. Is there anything else that you kind of wanted to expand on that?
I mean, I can keep going. You got any questions?
No, I actually don't have any questions now. No, I really liked that though. Kind of that connection and looking at how the blood-brain barrier and also how the GI tract, just how inflammation can affect both of them. And again, I really like to try to emphasize to my patients that whenever there's something going on in the body, looking at something in isolation, it's not as effective as it could be, just simply because your whole body is functioning as a whole, right? You never just have one thing. So I encourage my patients to just think about a lot of the different things that can be going on, and not to be pigeonholed into one area in that sense.
Of course. And it's good to find somebody who knows what they're talking about. I mean, everybody's doing what they do because people get into this because something helped them. And sometimes we get a little overzealous with what we believe helped us, and we lose some of our self-skeptability, which
for sure
is so important for making sure that we keep it about the patient and we keep it about the person sitting in front of us and not what we want to do. And being open and honest, being like, hey, I don't know, we're going to try it and see if it works. It usually takes 6 visits to know if it works. And if you agree, we can do that, as opposed to, I've seen this before, because most likely it's different, as opposed to we just keep going until you're better.
No, for sure. Yes. Yeah, no, I think a lot of the times it's a lot of experimenting. I feel like sometimes.
It totally is experimenting.
I hate to say that, but
as experimenting.
Yeah.
Because sometimes experimenting is exactly how you get the best results, because you're not just giving a protocol.
Yeah, no,
But at
exactly.
the same time, the patient should demand a plan and understand that
Yeah.
when there is experimenting, so that way they know
Mhm.
what they're receiving.
Yeah. Oh,
They
yeah.
know that and that
Oh,
way
for sure.
they know they find a practitioner with good integrity.
Yeah, yeah. No, I think many of my patients would say that I usually am like, okay, well, we're gonna give this a shot. This is what I think the best approach is gonna be. But we're gonna find out because your body's gonna tell me.
That's why I
So
refer people to you, because I know that anybody that I refer is going to get good care from you and probably up there with the best.
well, thank you. I actually went to school out at University of Colorado at Boulder, so I know I have a lot of people on here that are out in that area. So hopefully
Happy
they'll
to
be
help.
listening. But you want to switch us back over to the normal screen? Perfect. Awesome.
How do I make you the host now?
Oh, I got it. If you go to participants
Found you.
down at the bottom, and then you just click it over. Yep. And then you click more, and then yep, perfect. Awesome. Yeah, so anyway, thank you for that. That was fabulous. I love so I love doing these. I've been doing a little bit more of them just because this is something new that I'm trying out, just to try to get more information out to people. Because one of the things is we just literally talked about is that it's hard to sort through all of the stuff that is on the internet, and it is frustrating. So I'm trying to bring more people in that are knowledgeable, that know what, that are working in this field, that have different, not, educational bases than I do, so just different tools and things so that people can start getting exposed to this kind of stuff, because half the time I think it's hard to even just know that it exists. You know what I mean?
Yeah, exactly. And
Yeah.
we're there, like, I mean, if people are interested, Delta S Performance.
Yep.
We follow us on Instagram, follow us on Facebook, and find us on LinkedIn. We are putting out more content online now that we're sitting at home twiddling our thumbs more than in the past. Um,
Yes,
the whole goal is to just raise the education level, because if people understand what's going on in their body, then they will get better quicker. And that's our
for
goal, is
sure.
to get people better quicker. Um,
Absolutely.
DeltaSperformance.com is our website. Feel free to reach out on there through the website and send us messages. Um,
Perfect.
you can text our phone numbers. So New England is 617-383-4483.
Perfect.
Denver is 720-443-3023. We recommend text because we agree that we live in 2020.
Yes, absolutely. I know I do text as well. And it just, honestly, it's better. It's just
If it,
easier.
if it ends up being a conversation, sure, we'll just be like, yeah, why don't we schedule a time to
Yeah,
go through this and give you one-on-one time so you can get all your questions answered. But
exactly.
other than
Yeah.
that, like, if it's a quick question, you
Yeah.
don't need to have a phone call with us. Just shoot us a text and we'll schedule a time to make sure it works
Perfect.
for both our schedules.
Awesome.
Yeah,
And yeah, so everybody, I'll have all of those links below as well, so that you can grab those and pick those up if you guys want to go and learn more. Do you have anything else that's going on online? I know you can do a little bit of telemedicine, particularly if people are in your states, but is there anything else you want
I can
want
see
people
people
to
in
know?
person now. So
Oh, you can see them in
I
person
am
too.
open for
That's cool.
practice here in Colorado, and we are
Perfect.
open for practice hopefully the beginning of next week with Rhode Island.
Awesome.
Massachusetts, we have no idea what's going on there. So we're just
I know.
taking
It's
time.
crazy. All right,
Um,
last question, unless
oh,
you wanted to follow that up.
oh, no, I can, I'm a rambler.
Is there anything particular during this time that's been really, really helpful for you? It can be literally anything.
Getting outside,
Yeah.
making sure you get some sunlight. If you live in Oregon, that might be difficult. No, I'm just kidding. You should be in the sunny
We're
side.
about to have well, I don't know when I'm going to release this, but we're about to have 10 days of sun, and I'm really excited.
Oh,
But it's
that's great.
been raining for the past 10 days. So
Yeah.
I'm ready to get out.
Get outside, so you get some exercise, move around, make a plan, recognize that this isn't for forever.
Mm-hmm.
And so get out of your own head and out of your own way, so that you don't start thinking like, oh, this is the new normal. Just be like, okay,
Yeah.
you can look at data. You can ask some clinicians who are up on this stuff. Not every clinician is up on this stuff, unfortunately.
Mm-mm.
But for us, we've been planning on June 15th as a back to normal anyway. just based on the data that we saw from that was available at the time in March. And so things seem to be going along that track. And I mean, even if it goes through the summer, just make the best of it. If it is normal, just make the best of it. And it's okay to be okay with changes.
Yeah, absolutely. Awesome. Well, thank you again so much for all of that. That was really awesome. I'm like, this is going to be great. So, yeah, thanks again. And we'll have to have you on again soon.